Good afternoon, everyone. This is Maureen Dobbins. I am the Director of Health Evidence, and I'm so pleased to have you with us this afternoon to talk about school-based programs for preventing smoking in children and adolescents. What's the evidence? For those of you, if this is the first time you're joining us, this is our first webinar, let's call it of the academic year. We try to hold monthly webinars, except we took a break over the summer. And we're really excited to be starting up our webinar series again this fall. So just look forward to additional webinars that will be coming, that we'll be hosting throughout the remainder of this year and again starting up in January. So the evidence that will be discussed today by Dr. Thomas is actually based on let's call it two reports. So one is in 2013, the publication of this review in the Cochrane database of systematic reviews, and then published in the BMJ Open in 2015. So Dr. Thomas will be getting to that in just a moment. With respect to housekeeping, so just I would like to encourage all of you to post comments and questions to the all component of the website, to the WebEx. That way everyone will see those questions, as many times the questions that are posed are really interesting for everyone, and it allows them to follow along. So please press all when you're posting those as opposed to privately to the host. We do recommend that you use a wired internet connection, so particularly if this is the first time you're joining us, wired versus wireless. So we've learned over time wired works much better. And if you are having any problems, we encourage you to use the WebEx helpline. The number is here, and that will also get posted into the chat, so you can see that if you have trouble throughout the webinar. So just to quickly show you the health evidence team, the family is actually really growing here. And I was noticing today that it's actually looking a little one-sided in terms of all women, but this is who the team is, and just to know that putting webinars on is really a team effort in terms of identifying reviews and tagging them, and the development of evidence summaries and the PowerPoint and connecting with our speakers. So just to thank everyone who has contributed in the health evidence team for this webinar series. One of the main goals of healthevidence.org is to, in addition to making the evidence about the effectiveness of public health more easily accessible to public health professionals, our main goal is to really help make it easier for professionals to use that evidence in decision making. The value add of a resource like healthevidence.org is that it's going to save you an incredible amount of time in multiple ways. It means that, by and large, if what you need is a systematic review evaluating public health interventions, you really don't need to go to the large databases to find that. That's our job. We search weekly, daily. Our searching is happening to find the newly published literature at the systematic review level that's relevant to public health interventions. So everything in health evidence is directly relevant to public health practice in Canada. Everything in there might not be relevant in your particular jurisdiction, but someone in Canada that would fall under the public health scope in their jurisdiction. We are as current as we can possibly be at this point in time with our resources. At any given time, we are likely no more than 1 to 2 months behind the actual publication date of a review. We try to be really open in the process of what makes it into the registry, as well as how we critically appraise it. So we provide on the site a way for you to see our tools, our criteria, as well as provide the actual critical appraisal assessment, so the quality that we've assigned to that review. And of course, we know that Having access to the evidence is only one piece of the decision-making process. So there are other tools around evidence-informed decision-making that you can also access from the site to help you put that evidence into practice. And we've listened over the years. Some of you may know we've had various celebrations this year as we've celebrated the 10th anniversary of health evidence being launched. And over that time, we've consistently asked for your feedback on how we can continually improve the site, and we've done our best to respond to that feedback over the years to make the site as easy to use as possible. Again, for those of you that may be new for today, this is the model that we all have in our mind when we're thinking about evidence-informed decision-making, knowing that decisions in public health are extremely complex. They're made up of many types of information, research evidence just being one of them. So reviews like the one we're going to discuss today, we know are just one component of all the information that goes into decision making, knowing that there's also the community or local context, community and political preferences, the resources, of course, both human and financial, and that it's your public health expertise that helps you locate all of the relevant information for a particular issue in each of these domains, and then to pull it together, usually in collaboration with community partners, to identify what is the best decision in your area for that issue. Of course, many of you will also know with the National Collaborating Centre for Methods and Tools, which is a center I head up, funded by the Public Health Agency of Canada, that we talk about a 7-step process of evidence-informed public health. And today we're really looking at that, kind of synthesizing, understanding what the results of a systematic review are, and then thinking about how they might apply to public health practice. So I'm going to put you to work now for a moment and just ask you to comment on whether or not you've heard of the acronym Pico or Picos before. So we've just opened up the polling line. It's a yes/no answer here. We'll have that open for a few minutes while I let you respond to that. Generally, what we've heard in the past is that many of you are very familiar with this. And so if we I'm just going to move us forward now as folks are finishing completing that. But basically what Pico, the acronym Pico stands for is the P allows us to really define clearly who our population is that we're interested in, what the intervention is that you want to know about, what you're comparing that intervention to, what specific outcomes you want to know about in relation to that intervention for that population, and sometimes we also want to identify a particular setting. So for example, in today's review, these are interventions that are happening in a school setting. Other times it might be in the community or various other settings. We might also add in there a time component. Sometimes we might be interested in outcomes immediately after an intervention, or it could be outcomes that we want to know may still exist 1 year later, for example. So the value of a Pico question, actually I might just back us up there for a moment. The value of a Pico question is, when you have an issue that arises at the grassroots level from your community, it might be an issue, teen pregnancy, for example. But turning that into an answerable, searchable question, we can really be aided by using an acronym like Pico, because it then helps us to further articulate specific components of the population intervention, what we're comparing it to, and those outcomes that will really help us to really hone what that question is, make sure everyone is thinking about the question in the same way, and that then when you're ready to go search for the relevant information, it should help you find that information more quickly and more efficiently. So I have another question for you now. And this one is, how often do you use systematic reviews to inform a program or a service? And you can see here that we're just scaling that between always, often, sometimes, never, or I don't know what a systematic review is. So we're just asking you to choose one of those. And I'm just going to give you a few moments to answer that. Actually, this is a comment more to Olivia. I believe, Olivia, you're listening in, who's helping me out today from Health Evidence. Normally, I can see the answers as the polling questions come in, and I have a sense of where you're at with answering and also what types of results we're getting. I'm not seeing that today, so I'm a little bit in the dark as to what those results are.
Thanks, Maureen. So what I'll do is I'll close a little bit early this time, and hopefully you can see the results.
Okay, thank you.
Perfect.
And one of the reasons why we ask some of these questions, one, it helps to engage our users, so we know that interaction is really important to the effectiveness of webinars. And it also allows us to see, you know, really what the knowledge base is of those that are joining us on various topics. And it helps guide our future work. So just as what I'm seeing here in terms of the responses, there were a few, if we go back to the Pico question, we're about 50-50 of those who answered. About half had heard of a Pico before and half had not. So hopefully that was helpful in terms of learning about what that was. And if we can go back to question number 2, as I wait for those, it looked like the majority had answered that it was often or sometimes around the use of systematic reviews in decision making. So just like to introduce today, Dr. Roger Thomas is going to be presenting to us the findings of his review. Dr. Thomas is a professor in the Faculty of Medicine at the University of Calgary, and he also is the Cochrane Collaboration Coordinator also at the University of Calgary. And again, I've talked about the 2 reviews that this presentation are based on today, the actual Cochrane review that's published in the library, and then a newer publication in the BMJ Open in 2015. And with that, I will now pass the mic and the slide, being able to move the slides will go to Dr. Thomas. So welcome, Dr. Thomas.
Good morning, everybody. The other 2 authors are from the University of Oxford Department of Primary Care and the Systematic Reviews Unit. The second author, Ms. Julie McLellan, is probably the youngest bank manager in England. She got fed up with the banks because they were moving away from person care, and she started doing reviews at Oxford, and it's interesting how by doing them you learn to them. Because she's a bank manager, she had all the computational skills and exactitude of balancing, you know, the daily balance to be very, very helpful on a review. She and I exchanged 600 emails in which we took every one of the reviews back to an intention to treat format, which avoids the problem of what happens to people who don't participate. The third reviewer is the Associate Professor of Medical Statistics at Oxford. So we wanted to know the studies of children and smoking and preventing them are nearly all in schools because that's where kids are most of the time. That's where it's easy to find them. Over the last 3 decades, most of the research has been designed by psychologists, and they've used information. Most people find that information is not helpful. Social skills. Some kid offers you a cigarette. How do you refuse it diplomatically? Interventions to become socially more competent. This is more general skills about how to interact with people, interact with the other gender, plan your life, combinations of these, and then multimodal programs which might involve parents, teachers, and communities. Okay, I'm looking for the button to send the next slide on.
It's just above the title rationale. It's with the little gray arrows beside it, Roger. Yeah, you did it. Yep.
Yep. So we looked at children and adolescents, and the comparison was no intervention or a school intervention, and very importantly, the outcome was the smoking status of children who reported no use of tobacco at baseline. I think it's one of the important contributions of our review. Much of the literature jumbles up children who've never smoked, children who are experimenters, quitters, and triers. So you'll get percentages at the beginning of an experiment, percentages at the end, and you don't know what's happened. You cannot trace the intervention. So we decided we will get what's called a pure prevention cohort and follow them through. So we computed intention to treat, pure prevention cohorts for all of the studies. You've got another poll question here. So I'm going to press on past that. So what I'm going to present today is an overview of the included trials, a comparison of social interventions compared to no intervention, again for the kids who never smoked, some examples of social skills and social competence interventions. And I will mention right now that social skills interventions are 60% of all the interventions used worldwide, and they don't work. That was one of the important conclusions of this review. Some conclusions for practice, which is probably what you're most interested in, and then some conclusions for research. Now, we found 133 cluster randomized control trials in which the intervention is given to groups of people. This is very important statistically because if you give an intervention to a group of children in class, is it your intervention that has an effect, or is it the interactions among the kids in class? I mean, if you remember back to your primary or adolescent school days, lots and lots of influences going on in the schoolroom, kids you talked to a lot, kids you didn't. And one randomized control trial in which the intervention was given to individual children. Now, in these trials, there were 200 intervention arms. Some of them tested several interventions head-to-head. Nearly 500,000 participants from 25 countries. And I regret to tell you that the time of some of these people was wasted because we could not extract the data for the systematic review. And I should mention that our third author, Dr. Rafael Perera, she teaches the Cochrane course at Oxford. Despite his best efforts, we couldn't extract data from two particular groups of studies, and I'll come to that later on. So we're focusing on the 56 trials with 184,000 kids. Now, of these trials, 49 trials provided analyzable data with 73 comparison arms with 142,000 children. So that's a pretty large number of children from 19 different countries. That's very important. Many reviews have data from a limited number of countries. Now, 26, not surprisingly, from the States, 4 each from the Netherlands and the UK, 3 from Canada, Germany, and Italy, 2 from China and Spain, and 1 each from various other countries. So we have 4 continents involved, but in terms of Asia, we've only got China and Thailand. And then there's a second group where they provided change data. Now, the psychologists are always inventing different ways of analyzing their data. And they provided change data, often in the form of growth curves. And these are very difficult to meta-analyze because you cannot identify, as I said, the status of the kids at the beginning where they were never smokers, quitters, experimenters, or triers. And if they would say non-smokers, we'd have to, by the way, we wrote to all of the authors, all 133 authors, clarifying many points in their trials. Clarifying, does non-smoker mean never, or they're not smoking at the moment? So in this group, there were 16 trials with nearly 60,000 participants, of which 15 provided analyzable data, 12 from the United States, 2 from India, 1 from Canada. Again, they weren't able to be meta-analyzed with the group who were pure prevention cohorts and never smoked. And then there's a point prevalence of smoking, again, where they jumbled all the results up together. An amazing 208,000 participants with 110,000 participants from 11 different countries providing data, again, mostly from the States, and 1 each from various European and Latin American countries. So the problem is, at the baseline, we don't know the percentages of never smokers, smokers, quitters, and triers, and same for the follow-ups. So it's like a group of people enter a race, and a different group of people finish the race. So you have no idea whether training had any effect at all. Now, this is risk of bias. Now, the Cochrane looks at usually 5 risks of bias. So random sequence allocation, and the green bit is they had a low risk. And low risk, if you look at the Cochrane handbook, which is online at cochrane.org, it's best introduction to randomized control trials and how to conduct them, up to date and totally free. So they have a whole series of criteria for what is low, unclear, and high risk of bias in these dimensions. So with random sequence generation, for example, a strong method is a computer that generates a random number, and then the person is allocated to the group. And you can see there's a fair amount of yellow, nearly always because they would use a word like students were randomly assigned. It didn't say how they did it. Allocation concealment means is the researchers do not know which groups the people were in. This is very important when there's a subjective evaluation of the outcome, shall we say arthritis, and you're looking at joints and you're counting which joints are arthritic. Less important if you've got an objective measure. Some of the studies did measure cotinine, which is a byproduct of tobacco smoking, in the kids' blood or saliva, but very few did that, so we don't have really an objective measure, so you rely on self-report. There's a large literature on self-report, which suggests that probably they're fairly accurate. So there's could be a lot of bias because they actually didn't say whether the researchers were blinded to the allocation, just didn't say. The blinding of outcome assessment was, again, unclear because many of them didn't say whether there was blinding or not. Putting the kids in a room with a teacher and then collecting the forms afterwards in terms of surveys is not really blinding because the kids may know which arm they're in. Incomplete outcome data was not so bad. About half of them had complete outcome data, and obviously for those that are yellow and red, we computed intention to treat. Now I'll give a little more detail on this. If you take a group of people who are eligible for a trial and a certain number refuse, you start with a group who allow themselves to be randomized. Once you're randomized, you're in the trial, and so you must report the data for everybody who was randomized into the interventional control group, and if they drop out, then you assume, which is the most conservative scientific assumption, that they carried on doing their unwanted behavior such as smoking. So it's a very conservative view of how effective the intervention is. Selective reporting, it's called cherry picking. You'll see an abstract and they report 5 things turned out positive, but they had 10 things that they measured. This is not true of this literature. Very little selective reporting. Now, we come to the results. So for the pure prevention cohort, looking at all curricula, the odds ratio is 0.94, and the 95% confidence interval is 0.85 to 1.05, not significant. So imagine you go to your doctor, and you say to your doctor, look, the odds ratio of this medicine working is 94%. How sure are you that it works? And I say, well, if I repeated the experiment 100 times, I'm sure that the risk of you not getting better is 85%. There's a 15% chance you'll get better, and a 5% chance you'll get worse. So we like to have a very, very conservative approach. Same with a systematic review. We imagine we replicate the review 100 times with 100 different data sets, and that's the result. So you can see for all curricula, there appears to be a 6% benefit, but if you want a really strict outcome, I can't guarantee with 95% security that the result falls between 15% better or 5% worse. Now, if you look at the combined social competence and social influences interventions, there is a 51% improvement. 51% of kids fewer at the end of the trial were smoking than if they received the controlled intervention. So that's a very powerful result. And I am 95% certain that it's actually 72% fewer kids who will smoke or 13% fewer kids will smoke. So we take 1 minus 0.28, 72% sure fewer kids will smoke. 1 minus 0.87 is 13%. With the best estimate, 51% fewer kids will start smoking at the end of the trial than who received the control group. So any parent would say, let's sign me up for that. And the probability is 0.01. Look at the social influences, which is 60% of all the interventions. The odds ratio is 1. So it's like at the beginning of a trial, you put $1 down, and you say, did I win? They give you $1 back. You're neither better or worse off. And you could say 95% certain, 12% fewer smoke, 1 minus 0.88, or 13% more smoke. So if you want to be really strict, you wouldn't put your money on social influences. And then the multimodal programs that worked with parents, there's a Russian one that worked with teachers who smoked, there appears to be an 11% improvement, but again, the 95% confidence interval is rather wide. 27% fewer would have smoked, 8% perhaps more. So it all depends how you look at it. Are you a glass half full person or a glass half empty person? If you're a 95% confidence interval person, this is a convention. It was invented many years ago. Nobody's ever challenged it. It's a pure convention. Now, let's carry on. Now, more excitingly, if the trials were followed up for a year, and by the way, some were followed up at 1 year and some longer, we have some much more interesting results. If you put all the curricula together, one of the things a systematic review does, it takes 135 randomized controlled trials and makes them into one big monster trial if it's legitimate to put them together. You can't put apples and oranges together. And we measure what's called heterogeneity, and if the heterogeneity is below 70%, you can put them together. And if it's below 50%, you are happier putting them together. There are various conventions about this. So let's look at this. If you look at all curricula followed up for a year, 12% of kids, 12% fewer kids are going to smoke at the end of the study. Sometimes it was an 8-year study compared to if they took the control. That's 1 minus 0.88. And the 95% confidence interval is very reassuring. It's below 1. So it's either 1 minus 0.82, that's 18% fewer kids smoked, or it's 1 minus 0.96, 4% fewer smoked. So you could put your money on all of the trials. Now let's see where the real gold is. If you look at the combined social competence and social influences program, that 50% fewer children at the end of these trials, some of which stretched for 7, 8 years or longer, are going to not smoke, and it could be, with a 95% confidence interval, 72% fewer would smoke, down to 13% fewer. And again, the probability is 0.01. Now, if you look at the social competence programs, 48% fewer will smoke after 3 years. Now, the 95% confidence is just slightly wider because there are not that many of these programs. So it could be 1 minus 0.3, 70% fewer will be smoking at the end of the study compared to 12%. Look at the social influences, which again I say are 60% of all the interventions, including the DARE in the States with the uniformed police officers. What a waste of their time. The odds ratio is 1. Put $1 down, take $1 away. You neither won nor lost by participating. And if you apply the 95% confidence interval concept, it could be 12% fewer were smoking at the end or 13% more. And again, with the multimodal, it could be that 11% fewer smoked, but the 95% confidence interval is 27% fewer versus 8% more. We didn't do a great deal of discussion about the 95% confidence interval concept because really nobody knows where to go from here. There is a 99% confidence interval, which is much more restrictive. So if you wanted to know if you were going to take an anti-cancer drug, would it work or not, and you want to be 99% sure it had no side effects or it was effective, you might demand the 99%. Okie doke. Just checking in with headquarters. Can you hear me clearly?
I can hear you very well, Roger.
Right. Now, data by gender. Now, we've only got 7 studies in. This is one of the mysteries because we know that there's a lot of interest in do males and female students smoke more or less. We know that female students in many ways mature 2 years earlier, so they're 2 years further advanced in their development. You need to have very different programs for them for the males. Now, both programs seem to be effective, and the odds ratio for females is that 31% of the females would stop smoking, and these are studies only followed up for 1 year, and it could be 51% fewer or 4% fewer, probability 0.04, significant. And again, for the males, It could be that 34% fewer will be smoking. The confidence interval is less than unity, which is 1, so it could be 56% fewer or 2% fewer. I mean, if somebody came up to you and said, here's a medicine, I am certain that you will get 56% better, but it could be you only get 4% better, you'd say, hang on, can't you do better than that? Well, that's what the literature says, and that's where we have to go. Now, interesting, it's a mystery. Why would there no effect for follow-up longer than 1 year? In general, the programs followed up for 1 year were more intensive. So there's gender. No, this is not moved. Okay. Now, one of the other things was, over the last 30 years, and this really illustrates again the validity of doing systematic reviews, all of the researchers thought, should we have adults lead the curricula, and it's often a classroom teacher, it's the old graduate student. If there are any graduate students listening, you know how you're dragooned into doing things to help the professor. It could be a researcher, a wide range of people. Or should we get the peers? The idea is a 12-year-old will certainly listen to a 15-year-old. Will they? So actually, there were no effects for peer-led curricula. We don't know why. Was it that the peers were not well trained or the intervention wasn't appropriate? But certainly, for all curricula, if you had adults lead the curricula and teach them, 12% of fewer kids would smoke. For the social competence interventions, and I hope you're getting very interested in these, 48% fewer kids would smoke. And notice the confidence interval for each of these, the 95%, 70% fewer might smoke compared to 12%. The social competence plus social influences, 53% fewer would smoke. The pure social influences led by adults, no effect. Or the multimodal curricula, no effect. Now, some people have the thought, why don't we do an omnibus intervention? Let's have tobacco, alcohol, and drugs. And sometimes they do tobacco, alcohol, and marijuana. Sometimes they do hard drugs. Sometimes they do 10 hard drugs. Sometimes they do carrying weapons. Sometimes they add in early sexual experiences. Sometimes they carry violence. Most of them actually focused on tobacco and alcohol and marijuana, the more timid ones, and then the other interventions focused on alcohol, tobacco, marijuana, and hard drugs. Interestingly, there was no effect of these multimodal curricula. So the omnibus curricula with tobacco, drugs, alcohol, other risky behaviors were not effective. No explanation. And one reason is none of the researchers, except one case in California, ever got back to the participants, either the teachers, the people teaching the program, or the students, saying, what did you think of this program? Or try to discover if they liked it and why it affected them. So that's a black box. We don't know why the programs worked. So people kept on varying the programs, often copying parts of what other people had done and testing them in a different area. So a lot of water has been treaded in the last few years without discovering why these things work. And that's actually true of many psychosocial interventions. Next question. What about booster sessions? So people thought, okay, we've done our program for a year, 2 years, 3 years, 5 years. Let's have a booster, like launching a rocket into space. Another booster, yes, it'll reach orbit. So for the studies that followed people up for less than a year, 36 of them, the odds ratio is 94. So 6% of kids fewer would smoke. The 95% confidence interval embraces unity. 15% fewer might have, or 5% more. Now, for the studies more than a year, the boosters seem to work. Less than 10% fewer kids smoked than if in a control group, and everything is nice and below unity. 0.83 is below 1, 0.97 below 1, so it could be 17% fewer to 3% fewer smoked. Now, if we look at the social competence and social influences studies, less than years, only 2 studies that combine those 2 interventions. 50% fewer smoked, with a wide range in the 95% confidence interval, because you've got only 2 studies. It could be 74% fewer smoke compared to 4%. And then for the social competence and social influences studies that were presented and followed up for more than a year, 49% fewer smoked. Now, I thought it would be very valuable to show you what a social influences and social competence intervention looked like. Now, you may ask the question, is it easy to classify them? Yes, it is, but we put a great deal of work and a lot of thought into figuring out, is this a social influences intervention? Is it a social competence intervention? Now, so the social competence intervention, or an example by Spoff, an American researcher, it's called the Strengthening Families Program for Parents and Youth 10 to 14. So quite incentive. Imagine you are the parent, so this is what you get. You get 7 one-hour sessions for you and your kids. Those for parents, strengthening parental skills in nurturing, setting limits and communication about substances. Those for children, strengthen pro-social and peer resistance skills. So there's a lot of detail about parents. How do you discuss things with your kids? How do you set limits? How do you enforce them? How do you reward kids? And then a year later, they got 4 one-hour booster sessions. And then the social influences part, which is mostly focused on refusing offers of tobacco, was called life skills training. When you look at this literature, everybody's into life skills training. And the social influences was, you got homework and 15 classes of 45 minutes, knowledge about substance abuse, promoting youth skills in social resistance, self-management, and general social skills. So some kid comes and offers you a cigarette and you politely refuse. Self-management is planning your life. Sometimes they give them algorithms, consider the options, plan, implement and reevaluate. General social skills, interacting with the other gender, interacting with teachers, interacting with other kids and planning. And they used a wide range of techniques. Coaching, so you do it and they coached it and they say, why don't you try saying this, that might be more effective. Facilitating, you get stuck, don't know what to say. They say, well, why don't you say to, let's say Heather and I are working together, why don't you say this to Heather? Role modeling, so Heather role models, or perhaps Dr. Dobbins role models how to give an intervention to help people refuse smoking, and we all study it. Then we get feedback and reinforcement. I vividly remember the sex education classes in my high school at age 12 with the gym master holding up a condom, highly mystified. He looked embarrassed. A classic example of providing knowledge, no coaching, no facilitating, no role modeling, no feedback, no reinforcement. So that's an example of a social influences intervention intended to give you in-depth ability about tobacco, alcohol, or drugs, and how to refuse it. Then they got 8 units in the 8th and 8 in the 9th grade, so they really got quite a lot of instruction, but how much is 8 units in a year? So the program deliverer were life orientation teachers who teach mandatory life orientation health education course in schools. So general and substance-specific life skills, decision-making, stress management, jolly old stress management for the 12-year-old, affect management, how to manage your emotions and not fly off the handle and go postal, assertive communication, how to be assertive without getting up people's noses, how to resist peer pressure. I actually remember a 14-year-old, I was a 12-year-old, take me by the ankles and forcibly propel my head into the ground. A guy with amazing red hair, so I don't think I could have resisted peer pressure by him, except by running faster. Role plays, so role plays are dearly beloved, in which they do role plays, group activities, skills practice, individual workbooks, and educator's manual. So they went really quite thoroughly into providing life skills training. Sometimes they do skits. In Germany, they got to meet Olympic athletes. There's a wide range of interventions that have been tried to make it interesting to kids. Now, I'll give an example of Resnica, which is an example of combined. This is another one. And this is the social competence keep left harm minimization. So decision-making for reducing physical, social, and psychological harms from tobacco and drug use. So went into the physical consequences, psychological and physical ones. So they analyzed the context and cues for smoking. They got really detailed and cue-oriented. For users, an additional focus on addiction prevention, reducing intake and quitting, individual workbooks, and educator's manual. So you can see the psychological emphasis in these interventions. So I presented the results. I've given you examples of the social competence interventions which are effective, the social influences which are not. Interestingly, when you combine them, they're effective, but nobody can take the two apart when given together, so it may just be the social competences. So here's the summary. There are significant effects preventing smoking compared with controls when we look at kids who had never smoked. So if you looked at all curricula, for less than a year they were effective. If you looked at for more than 1 year, the combined social competence and social influence interventions were effective even if you followed them for less than a year, the study was less than a year, or more than a year. The social competence interventions at longest follow-up were effective. Implications for research. We need further studies of social competence and combined social competence and social influences programs to explore the potential of these interventions. We need further research, very importantly, to design and test programs that will be optimally effective for both genders. We need research to identify factors that can be tailored to the requirements of different ethnic groups. We know more about ethnic groups in the United States from cultures compared to, shall we say, the same group in the Middle East or Africa or Asia. So we need to know much more about them in their home environments before migration. And we need studies that follow up participants for more than 1 year. Very importantly, studies should clearly identify and follow separately students in different stages of their smoking career. Never smokers, which we focused on, experimenters, quitters, smokers of different frequencies and intensities. And that needs very carefully measuring. When you look at some of these studies, it's very hard to figure out how long the experimenter was experimenting for. Because otherwise, if you lump them all together, you get composite change rates and point prevalence scores. So you just get a group, 20% smoking at baseline, 40% 2 years later. You can't make head or tail of it. So the outcome measures should be standardized at trial design stage. There's a wide range of outcome measures, probably due to the fact that 8-year-olds have a puff and they borrow from mum and dad's cigarette pack or something at school. And then later on, after about 2 years, they begin to adopt a more adult pattern smoking more by themselves than in groups. Then they go from smoking once a week to several times a week, several times a day, and then become a pack a day. Studies are needed across all cultural areas of the world. There's minimal information on the costs of designing and implementing these programs. So economic evaluation is important in view of the fact that many of the interventions have not proven their effectiveness. Poll question 4. Over to you, Heather and Dr. Dobbins.
Thanks very much, Roger. So some of you answered this question earlier, but we'll ask it again now, and you can reflect yourselves if you've changed your mind after listening to Dr. Thomas's presentation today. So school-based interventions to prevent children and adolescents from starting to smoke. We'll open that poll and comment whether now you strongly agree, neutral, disagree, or strongly disagree with that comment. And I heard a beep there that I'm really hoping means that we didn't lose Dr. Thomas, because I had a question that I was going to ask him just while folks are completing the poll here, and it was a question that I saw come in during the presentation of the results. That is, you presented the results, Dr. Thomas, for covering the whole age group, which is ages 5 to 18, according to the Pico question outlined. And I'm wondering if you did any additional analysis looking at elementary school-age children versus high school-age children, adolescents, and whether or not there were any differences in the findings if you actually looked at their ages.
Good question. So in a systematic review, you specify all your questions ahead of time, and you're not allowed to invent things later on. So we actually didn't analyze them by age as a pre-specified question, but a reviewer asked us to, and we did. There was no difference in effectiveness for those 5 to 11 compared to 12 to 18.
Okay, great. Thank you. So I'm actually, Olivia, I'd like to go back, if it's possible, to the polling question, the polling question number 5. I don't know if we can still ask that now, but just wondering if you can comment on whether or not you agree with the findings that Dr. Thomas has presented today. And you can let us know whether or not you strongly agree through to strongly disagree with those findings. So we've just posted that again, and I'll keep track of that. Certainly if you disagree or strongly disagree, it would be, if you feel comfortable to post a comment or question as to why, and then we could ask Dr. Thomas to respond to those. So just while that's being completed, Dr. Thomas, I have a few other questions that have come in here. Let's see. Nope, actually there aren't any new ones there. So, but now is the time. We have about 14 minutes or so left with the webinar. So if you do have some additional questions, now is the time to ask those. And I'm just going to come back now to the polling results and see if we can get those posted. And just here, generally what we're seeing, Dr. Thomas, is most are saying, most of those who have responded have said they do agree with the results, and we just have 3 that have said neutral, and 1 says they strongly agree. None are disagreeing or strongly disagreeing. Maybe I'll just ask again, Dr. Thomas, you know, what are the reactions you've experienced when you've presented the results to various audiences?
I've had quite a few emails from people in the States and England who are responsible for tobacco prevention asking for details of the study. And they're along the lines of, if you rephrased your poll question, do social competence and combine social competence and social influences interventions prevent smoking, I think you get a different set of answers. Yeah. Because I've outlined the parts that don't work. Just the social skills ones don't work, and the multimodal don't work. And the ones with just using peers don't work. So if we focus on things that do work, you probably get a different set of answers. Right. Always get an answer depending on one's question. Mm-hmm. Mm-hmm. So I'm just looking again to see if we have any other questions that are being posed. I'm not actually seeing any that are coming in, so hopefully I'm not missing any that have come in, and I'm just clicking through here. Probably our readers are all out preventing children smoking. Sorry, could you say that again? I said probably all of our attendees are busy out preventing children smoking. Right. Yes, that could be. I do see a question posted here, so I'm just going to, just looking at it. So the problem is that it seems not realistic to be able to offer in school that much of interventions. Example, 8 per year. What do you think? Again, it comes back to the cost of doing it. If the intervener is mostly the classroom teacher, there's only the opportunity cost of not getting a math class. If it's a graduate student, it's part of their requirement for a degree to participate in this, then there's no cost. So that's really the issue. It's a question of time. And a lot of schools have very, very tight timetables. So it does show that having 8 boosters in grade 8 and 8 in grade 9 works. Nobody quite knows whether it should be 6 or not. From one perspective, 8 lessons in a year when you go to school about 240 days of the year is not very many. Nobody quite knows how large the intervention should be and at what point it tapers off. Like with a medication, we all know that once you've reached a certain level of the medication, you get no more benefit. We don't quite know with these interventions at what point there is a point of diminishing returns. Because the kids get bored with it too. You'd obviously have to have more and more interesting and more advanced interventions. Just as a comment, they're beginning to have gaming interventions where you move up to different game levels as you work on, preventing people smoking. And we don't quite know how that's going to work with the gaming community, because there are very few of them, but that certainly has the possibility. I mean, some gamers spend hours online. Then we'd start another problem of getting them addicted to gaming shows on preventing smoking. In what intensity you do it? And of course, that's free. If the kids do gaming, there's no cost to it because it's the kids who operate the intervention. Right.
So, a related question is: have you presented these results to teachers or within the realm of schools, and what has their response been to this level of intervention?
No, I haven't. I'm a busy family physician, so I have a limited amount of time for that. I actually have presented to pretty well most of the school regions in Alberta on where the school teachers have compulsory education. I presented findings of this and also other interventions on children's behavioral problems, but I haven't presented this particular systematic review.
Great. So a couple of other questions have come in. So one of them is if you could define what is the definition of social competence within the context of this report. So could you just go over that again, please?
There's actually a detailed definition both in the BMJ article and in the original review. So we're talking about social competence or social skills?
So social competence.
Yeah, okay, let's go back. Yeah, so let's look at SPOF. I've gone back to slide 30. So the idea of social competence is to make you more competent as a child or adolescent, not, hello, yeah.
I was just changing the slides there.
Not particularly in regard to addiction. So if we look at what SPOF did, they normally work with the parents and then they work with the children and often work with both together. So with the parents are urged to make the family unit more competent. And we've also done a separate review on interventions in families, which we presented as part of your series, Heather. So the idea of social competence is that the family unit interacts a great deal with the concept of authoritative parenting. Authoritative parenting means I have lots of interest in the kids, I interact with my children a lot, I set rules, I make sure they're enforced, as compared to authoritative, do as I say, or neglectful, do anything you like. So the idea is to strengthen parental skills in the areas of interacting with the children, discussing things with the children, cognitive behavioral therapy with the children about what they should and shouldn't do because they're always experimenting. Improve your nurturing skills, because some people are good at setting limits but not good at nurturing. Helping people set limits. How do you communicate with your children? The whole idea of communicating well with your children so they bond with you well, you're pretty well on the same page, and they can discuss new events and you help them. Those for the children include, obviously, because they work with the parents in the family unit parts of the intervention in strengthening their skills as children, relating to parents, agreeing with the parents about setting limits, but strengthening their pro-social skills, giving them general skills for interacting with people, how to interact in groups, how to interact with friends, how to plan, how to set priorities. As I said, quite a few detailed algorithms for approaching, what are my options? What's the good option? What's the bad option? What are the barriers to achieving it? Which is what we typically do with many kinds of clients. Then they teach them peer resistance skills, because we always know that there are certain kids in schools. I can think of my own high school, the naughtier kids, who would try to encourage other kids to get up to bad behavior. So it's teaching them ways of evading the influence of kids who want to do bad behavior and actually being a positive role model. So that's what the social competence is about. And it doesn't teach specific skills about drugs, alcohol, or risky behaviors. Focuses on the parental and the child skills, and the child skills in relationship to the peers.
Great, thank you, Dr. Thompson. So another question here is, can these results be extended or applied to other substances such as alcohol and marijuana?
We haven't done the alcohol and marijuana studies. There are Cochrane reviews on those. and the review group is from Italy. So if you look up the Cochrane review on interventions to prevent alcohol and drug use, I've done one on mentoring to prevent drug use and another one on mentoring to prevent drug and alcohol use. There are very few mentoring studies, and those that are, about half of them are effective. So the key interventions are in the Cochrane database from the Italian review group.
Great, thank you. And possibly what we could do, just to answer a question that's come in, the last question I see there around getting the presentation. Yes, we will post, I think we have your permission, Dr. Thomas, to post these slides after the presentation today, as well as the audio recording from today. And what we can also include are the links to these additional reviews that you've just discussed.
Right.
A couple more questions. We have a few more minutes left. So one of them is, this person has said, I think it highlights the importance of mental fitness, relatedness, autonomy, and competency. The more mentally fit students are, the less likely they are to get into risky behavior. Just wondering what your comments are, Dr. Thomas, on that.
In all of these studies, I've never come across the word mental competence. Nobody's ever measured that, and that's certainly a very interesting approach. And it would certainly tap into the idea of pro-social peer resistance skills and the ability to interact well with the parents and not be rebellious and contrary to the parents. So that might be a very important area and a very interesting concept. Can the person who sent it in send us a little bit more about that?
So that so a request there from Dr. Thomas to the person that submitted that, maybe just a bit, if you know a bit more. And the comment is Dr. Bill Morrison, Joint Consortium School Health, Positive Mental Health Toolkit.
Okay. I mean, there are concepts of, child resources, the 31 child skills, including having effective parents, effective grandparents, 31 sort of basic resources that kids should have, and that relates to those concepts. I would say if you're going to do reviews, it's important to have the same outcome measures so you can compare them across reviews and you're not blocked by having non-comparable outcome measures. So that's one of the important conclusions of our review, is that we need to have a common set of outcome measures so that we can gather data for large, put together many studies and put them together across societies. Right.
And so we just really have a minute or so left here. Someone had a question, when you were talking about the social competence, yes, Dr. Thomas was talking about the Strengthening Families program that was being described on slide 30, so when that is posted. One other question, Dr. Thomas, is just clarification, was peer delivery not found to be better than adults, or peer delivery not found to work at all?
Peer delivery was found not to be competent compared to no peer delivery. So it seemed to be irrelevant to train the kids. And as I say, we don't know why. Was it the wrong kids were chosen? There's one series of studies in England in which children were chosen by their peers. About 18% of them were nominated. It's a very large study that they put into many salami publications. And they were nominated. And what they found was they often talked to the other peer interveners. They talked to their friends, and they stopped quite early on. So nobody quite knows whether this works. It kind of relates to typical kids' behavior. You talk to people you're comfortable with. And it did seem to have an effect in reducing use of tobacco. So there's an example of a peer study that worked. But in general, having peers present these programs, mostly developed by psychologists, did not seem to work compared to doing nothing, just offering them control.
Great. Well, I'm going to draw us to a close. I want to thank you so much, Dr. Thomas, for your time today, and really fantastic presentation. You have a real skill of taking really complicated numbers and data and presenting that in a really usable way for many of us that are on the call. So thank you so much. And also knowing that you're a busy family physician clinician who is, really in your spare time doing these really wonderful Cochrane reviews is just fantastic that we have you doing this type of work. And I would also like to take this opportunity to thank all of you for joining us today. We've had a really great turnout for today and really wonderful questions and comments being made, and we have some folks here talking about some links that they're providing to various resources that will be available to all of you. You'll see here that I've just put up that slide again around evidence-informed decision-making. You know, today we really focused on what is coming out of the quantitative research around what works in preventing tobacco use among children and adolescents, and of course, to use in making decisions for your particular areas that you work in, you would use other additional types of information to help you in that process. So again, just a final thank you to everyone. The contact information if you have additional questions for us. Also, I'll make the offer to say if you have ideas on webinar topics that you would like to see us cover in the future, please use the contact us email address. And then we're also just letting you know here where you will find the PowerPoint and information from today's webinar will be posted in the next few days at Health Evidence. Just keeping in mind you do have to log in using your username and password, or if you aren't already a member, you'd create a profile, which is very, very simple and easy to do. So with that, thank you very much, and hopefully you will join us again in October. We will be talking about obesity prevention in October, and look out for our flyer that will be coming out soon. So enjoy the rest of your day, and we'll talk to you again.